So as you can see, this is actually a traumatic cataract. This patient had a trauma around 1 year ago. You can see that even without actually rotating the eye, you can see that the edge of the lens is over here. So this is all the zonulizers, and you can see the edge of the lens. So by just looking at here, you can see that it's around from 2 o'clock to the 4 o'clock or 5 o'clock. And when you mobilize the eye, you can see that the lens actually is a little bit mobile. So we'll be able to tell once we go into the AC if the lens moves a lot. You can see that the lens moved down a little bit. Again, I tried to actually make a long tunnel for this because in case if we need a sclerofixated lens, then it's better to have a longer tunnel because the wound will be much bigger. You can see one sign of zonulitis or zonular dehiscence is that when we do the capsularesis, there are a lot of folds on the capsule, and the counter pressure is when you do enough phaco, you know that it's different. The counter pressure, when you actually try to do the CCC, if it's very unstable zonules, you will know that it feels different. And the capsularesis is much more difficult to do because the zonules act as a counter pressure. The capsularesis I'm doing now is slightly smaller, but I think it's good enough for the time being. I might choose to do a hydrodissection first. It's important to do a very thorough hydrodissection if possible. Okay, so you can see that the ring is building up. And we're trying to release the pressure in the posterior capsule because, yes, you can see that the water coming out, gushing out, okay? And we'll try to see if we can rotate it. If we can rotate it, I think it's better to rotate it counterclockwise because there is a zonulitis in that region, it's better to rotate the lens towards the zonular dehiscence. So I'm going under the capsule, try to isolate, you see. I'm trying to use the viscoelastic to dissect the capsule away from the lens. Now, for the introduction of the CTR, it's important that we have to think, okay, where should we put the CTR and how and what direction we should do it. Because you can see the zonulitis is over here, okay? So if we put the CTR that direction, in fact, we are creating more troubles because the CTR, when it threads through here, it can cause more tension on the zonules, okay? So in other words, we should only think about putting the CTR in that direction. So it's an anti-clockwise position. So here's the CTR. So we think about what we do. When we introduce it, we're trying to put in in the anti-clockwise position. Okay, thread through like that, and we'll go in through here and then just thread through. Okay. Make sure the end of the capsular tension ring stuck inside the bag. Okay, so hopefully everything's okay. I try to use the hydro delineation. I try to visco express a little bit more. It's always not a bad idea to dissect a bit more. Make sure the lens is really free away from the cataract. Okay, all right, so we can start phaco. I usually use divide and conquer approach. The lens is still very unstable, you can see. It's still important to make sure that you are not pushing the lens too much, because any pushing can cause more sonil problems. And the CTL can't stand with sonilizers too much. So it's still very important to have a gentle phaco. It's easier if it's an AC. The lens will be easier to remove. It's not causing that much sonil stress. So it has to be very gentle. The back is very mobile. So everything has to be very gentle. And you can see that I'm trying to do this cracking over this direction because the sonil is on the temporal side that has the sonilizer, so I'm not pushing the lens in another direction. So we are going down now to the last quadrant. But sometimes I can adjust with my paddle too. So I'm trying to not pressing the paddle to the full strength. One thing with the capsular tension ring is that after the phaco, you see the capsular recess is still pericentral and it's very circular, which is good because if there is any capsular damage, you won't see that. You'll see a D shape or the distortion of the capsule. So far so good, and there seems to be no vitreous. I will just insert some visual OVD, just try to block this area because this is where the vitreous can comes out from. So when we do IA, I do it very slowly. When you do with the CTL in situ, it's always more difficult to absorb because we have done a little bit of that complete hydro dissection. It's making it easier. I won't go very heroic in case I can't suck off all the capsule, because as long as the center part of the bag is clear, I think I'm happy. So usually when the sonilizers happen in this direction, the lens may have a little bit of injury too, so it's not uncommon. But the capsule seems to be okay. It's good to rotate the lens so that the haptic stays at where the zonulizers is. So that's why I will rotate a little bit.